I was asked to provide a scene setter around integrated approaches, particularly focusing on health systems, before we move into the two talks of this final session, which will be on lessons on integrated care from Georgia and from the Veterans Administration in the United States. So a couple of questions as we start to close this meeting for you to be thinking about now and in the future. So do you believe that the elimination of hepatitis C as a major public health threat by 2030 is possible globally? And do you think it's possible in your country? And in which populations do you feel hepatitis C elimination is most feasible now? And that's focusing really on the microelimination approach. So, we all know the history of HCV treatment, and we know how difficult it was really to integrate care given the kinds of treatment, interferon and pegylated interferon with ribavirin, and so on. But now we've moved into the elimination era, and the elimination era allows us to think of new models of care, and particularly how we're going to integrate that care. Well, I don't know where my disclosure slide went to, unless I just blew past it, but I'll just say I have received funding from AbbVie, MSD, and Gilead for various research projects and ad boards. We're all aware that WHO has its first global health sector strategy on viral hepatitis. I worked 11 years at WHO. We dreamed of having a hepatitis strategy one day. When I left, that strategy came about. I'm not sure if there's any scientific association with that. But what I think is important is that it's not a viral hepatitis strategy. It's a global health sector strategy. And throughout that strategy, there's emphasis on where viral hepatitis fits into the entire health system. So we cannot achieve viral hepatitis elimination in isolation. And so throughout this talk, I'm going to give examples of where we need to be thinking about integrated approaches as we treat viral hepatitis elimination as a public health threat. And WHO, as you know, puts forward, these are the hepatitis C targets, but there are also specific hepatitis B targets, puts forward a series of targets, and we need to think about how we achieve these targets in the context of an integrated health system. They put forward, for example, a target specifically around harm reduction, which means that we can't address hepatitis elimination just in hospitals and clinics. We need to be engaging with addiction centers, drug and alcohol centers, and other kinds of harm reduction centers. And WHO also puts forward as an organizing framework the continuum of care, as we're all familiar with. And what I find interesting here is that after achieving sustained virologic response, WHO says the story's not over. It's also about follow-up and chronic care. So that means chronic care related to potential liver damage, typically because of late presentation and starting treatment late, but also care to prevent reinfection, which means, again, that ID departments, hepatology departments, and others in hospitals need to be in contact in order to refer their patients to harm reduction services that are often outside of the hospitals and clinics. So all of this really requires us to think about what kind of paradigm change do we need to undergo. On the left here, you have the health systems building blocks as WHO sets them out, the 6 building blocks from service delivery to leadership and governance. We added in terms of hepatitis elimination, the importance of communication between all of those parts of the health system, but also the importance of patient engagement, or really what I would call also risk group engagement, in order to achieve the interim goals of any health system, which are access, coverage, quality, and safety, and the overall goal, which is improved health. And you'll see WHO put in parentheses, level and equity. So it's not just about achieving those targets set out in the for a country to achieve those overall targets set out in the strategy, but also to achieve them in an equitable manner. So if you're leaving any population behind, I don't think you can say you've eliminated viral hepatitis as a public health threat. So WHO later reorganized their framework for how they think about a health system, and you'll see here it's become more circular to show the dynamic interaction between the different parts of a health system, and how we always need to be asking ourselves, are people at the center? Because we know that so many of our approaches make it so difficult for people, clients, patients to access the needed services. Here's an example from a small study we carried out in the 5 Nordic countries. We based on an earlier study we ran with just patient groups called HepCore, we thought, let's ask patient groups, representatives of risk groups, representatives of clinical societies, and the focal point in the government itself in these 5 small, well-resourced countries about the policies that they have in place. We thought it would be a quick study. In 6 months, we would have all of the data. We'd be able to share it and publish it. 2 years later, we found that the primary results were the widespread disagreement on what official policies were actually in place in these countries. Even in a small country like Iceland, and I know we have representatives here, and bigger countries in Sweden, Norway, and Denmark, you can see here, without going into detail, the percentages on almost every domain around national coordination, prevention, testing, awareness. There was widespread disagreement about the official policies in place. So I think if we're going to have integrated care, if we're going to engage with stakeholders, we need to make sure that the leading stakeholders all understand what is on the books in the countries, what is possible, and also what needs to change in the countries in order to achieve hepatitis elimination. One important issue for achieving elimination is to look at who's able to prescribe in countries. This was a study carried out across European countries, and here you'll see that prescribing is restricted to specialists. I've presented this before, and many specialists in some countries have said, well, we really don't need to expand the prescriber pool. And in some cases, in some countries, that's been the case. But what we found is that there, and as I'll show in the examples, specialists need to collaborate with prisons and harm reduction centers in order, through telemedicine or through on-site clinic visits, to ensure that treatment can be prescribed without the patients necessarily having to go to the hospital or clinic if that's too difficult for them. So I wouldn't argue that every country necessarily needs to expand the prescriber pool. I think some do, but if not, then we need to look at how collaboration can be better set up. And similarly with testing and screening, we need to get testing and screening out of the hospitals and clinics. We've just held a European testing week with more than 500 organizations involved. And a couple of years ago, when we were asking the patient groups what kind or where do you have testing opportunities outside of hospitals, they mentioned general practitioner clinics, OST clinics, NSP, and then under other they mentioned NGOs, prisons, private laboratories, and they mentioned that one of the big problems was getting all of the data together so that their national surveillance system, I don't know if Ivan from WHO is still here, but he would appreciate to know that people are thinking about how do they get that data centralized to the government in order to be able to report it back, because while we want to have as many testing sites as possible, we also want to be able to know who's been tested, who's tested positive, and how can we link them to care. And as you'll see here, the numbers are quite low. So across 20 countries, 3 had reported at that time NGOs, 1 had a mobile clinic. These numbers are changing. A few were testing in prisons, most were not, so on and so forth. So all that to say that we really need different models of care, and we've been hearing about some of them here at the IVHEM meeting. We need to be thinking about how care can be better integrated into the drug and alcohol clinics, as I mentioned, also in some settings into primary health care and GP centers, into prisons, into community health centers as well. So I want to run through a couple of case examples. This is from the Shared Addiction Care Copenhagen program that we've been running from the University Hospital in Denmark. On the left, you'll see how care was organized in Copenhagen before in a very basic diagram here. We essentially had the addiction center where some of the people who inject drugs would go, and if they wanted to get a hepatitis test, they either had to go to the lab or go to the hospital or go to the lab to pick up the papers in order to go to the hospital, and in the end they had to kind of run around a bit, and very few people were tested basically until this program started. What we did was reduce or remove the role of the lab and greatly reduce the role of the hospital so that the 15 addiction centers in Copenhagen, in agreement with the municipal government and the university hospital, people who inject drugs, when they go to those centers, can get tested and they can get treated without ever having to go to the hospital, without the specialists ever having to go there, through telemedicine and an integrated IT system. And telemedicine is just really a fancy word for transferring the records to the hospital, making phone calls, using email, prescribing the DAAs, and having them taken over to the addiction center. So it was quite a radical change for Denmark. Unfortunately, until November 1st of this year, we had fibrosis level restrictions, so many of the people who were testing positive actually did not qualify to get treated, and all of that's changing now when restrictions were removed on the 1st of November. Here's an example of HCV testing at pharmacies. I don't know in your countries how often you're allowed, or how many pharmacists are allowed to perform tests actually at pharmacies. But in Birmingham and Manchester, they have a pilot project at 8 pharmacies that already provide needle and syringe, distribute needles and syringes, where they've put in the gene expert that we were talking about yesterday, where with just a small finger prick, you can draw blood and run a rapid test. So in these 8 centers where they know active injecting drug users are attending, they've installed the gene expert, and basically in these 3 steps, they're able to get point-of-care RNA results in just under 1 hour, and then through their care pathway, if they've tested positive the whole way through and they're willing to get treated, you'll see at the bottom their results are sent to the general practitioner. So they don't go straight to the hospital, they go back through the GP, that's the way their system's organized. A database entry is completed, and then they're linked to care in that way. So I'll be looking forward to seeing what those results give us, but I think this is quite ambitious and important in order to have testing in pharmacies where we know active users are attending. So the microelimination approach was mentioned. I won't go into detail, but when I presented last year, we were just putting forward the idea of microelimination because it's so costly and complex and daunting to undertake full elimination for some countries. You can break down the process into smaller parts. We've now released operational guidance on how to do this, and I won't go through all of it, but essentially we call for developing a plan to have regular annual reporting on the results, and for this to be a multi-stakeholder integrated approach. No matter how small or how big your microelimination project is, we think these are 4 important steps to follow, whether it's in cities, whether it's in a particular population or in a particular clinic. A third case that many of you are familiar with from John Dillon and his colleagues presenting in Tayside, where they're seeking regional elimination. In their own words, they say that they'll be using an integrated combination of pathways to target all groups infected with hepatitis C, and that this complementary service pathway includes conventional nurse-led outreach programs, pharmacist-led treatment of patients on OST, community pharmacies, treatment in prisons, treatment by embedded hepatitis specialist nurses in addiction treatment centers. So while it's overseen by specialists, they've delegated prescribing and they've delegated care to these levels in order to have a comprehensive regional elimination program. They're making good progress, and they'll most likely be one of the first major regions to be able to declare elimination. In terms of prisons, Javier Crespo and his group have been able to eliminate hepatitis C in a single prison in the El Dueso prison in the north of Spain, where prevalence, as you can imagine, was much higher than in the general population, and where they knew that this was one of the few times prisoners would be engaging with any health system. So they thought, let's offer them all a test. This was run from a hepatology department at the university hospital through telemedicine in collaboration with the prison medical authorities, so that they could test and treat within the prison. And here are the results from the beginning to the end of the project. They've gone from almost 13% prevalence to almost no prevalence. Of course, prisons are dynamic institutions, so they now need to maintain that program to make sure that new prisoners are tested and, if positive, linked to care. So we've heard that only 12 countries, according to the Polaris Observatory, are on track for elimination. Here they are, and I know some of you are in the room, and congratulations. A year ago, it was 6 countries. Some countries dropped off. Some countries have been added on. Some countries are complaining that they should be on, and they're not on this list. So my question to you is, who's next? And let's hear from Georgia about how they're doing, and then we'll hear about the Veterans Administration after that. Thank you.